First of all, I would like to thank you for this warm welcome. And I would like to express my sincere gratitude to Professor Pramod Kumar Sarma, the President, Patiksha Educational Trust, and Dr. Satyendra Deka, Principal of PIPS, for another distinguished guest and the organizer for this webinar on COVID-19. I would also like to convey my sincere thanks to PIPS for inviting me for this talk. So first of all, I would like to share my screen. So the talk which I'm going to share now entitled Recent Advances in the Management of COVID-19. So for the complete information, it should include the information on infection caused by coronavirus with special focus on COVID-19. It should include the morphology of the virus and its mechanism of disease progression. It should also include the clinical symptoms, preventive measures, but these two topics has been covered extensively by the speakers yesterday. So the main topic included in this talk includes the treatment guideline against COVID-19, which includes antiviral therapy, immune-based therapy, antithrombic therapy, oxygen therapy. Apart from which, we're having the future trends, which includes the vaccine cell therapy, stem cell therapy, vaccine, and herbal treatment. But this vaccine will be covered by the expert from industry, Johnson & Johnson. Dr. Roy will be covering it tomorrow. So this I am not going to cover. So first, let's give a small introduction on coronavirus. The figure has been adopted from CDC, Centers for Disease Control and Prevention. So this coronavirus is not new to us. This coronavirus was identified in 1965 by Tyrrell and Bino. So at that time, it was not named coronavirus. It was named by a code B814. The code was B814, but later it was named as coronavirus in late 60s. Why? If we see the reason, you can see the figure left side. This is the electron microscopy figure of coronavirus. We can clearly see the projections, the crowns on its surface. Because of such presence of crowns, this coronavirus was named as coronavirus. So this virus is found to broadly distribute among animals, humans, and birds, and known to cause different diseases, largely respiratory diseases, neurologic, hepatic, or enteric diseases. If we see, earlier to 2019, there were 6 species were identified which invades the human being. So the first 4 species which are mentioned as HCOV, human coronavirus. So HCOV229E, HCOV-OC43, HCOV-NL63, and HCOV-HKU1. So these are responsible to cause mild human symptoms related to common cold in immunocompetent individuals. But the other 2, this SARS-CoV and MERS-CoV, these were resulted in endemic. SARS is severe acute respiratory syndrome coronavirus, and MERS is Middle East respiratory syndrome coronavirus. So this SARS-CoV, it eradicated in 2002 to 2003 in China, and the fatal rate for this disease was 10%, whereas MERS was more fatal than SARS, and the death rate was 37% of the infected persons, and it occurred in Middle East in 2012. So when uh, as I said that earlier to 2019, there were 6, but in 2019, we have come across the new coronavirus, a novel coronavirus. So this was initially named as NCOV, 2019 NCOV. N, this is a novel coronavirus, which was originated from the Wuhan, we all know this, from the Hubei province of China. So later, this virus was named as SARS-CoV-2. Why? Because there's a similarity of SARS-CoV, which has eradicated in 2002 to this novel coronavirus. So this was named by the International Committee of Taxonomy of Viruses. So later, who declared the disease name as COVID-19 as an acronym of coronavirus disease 2019, and it was renamed. The name was given on February 11th, 2020. Just exactly 1 month after World Health Organization declared this disease as pandemic outbreak as good, pandemic outbreak. So till now, this virus has affected 215 countries all over the world, with 5,684,802 cases till date, infected cases in with coronavirus, and with a death toll of 352,225. That is incurs around 13% of the recovered patients. So this is about the COVID-19. Now, if we see the morphology of this coronavirus, the spikes what we have seen in the electron microscopy, those are the spike glycoproteins. These are S, right? So apart from this spike glycoproteins, okay, according to the electron microscopic figure, the size of this virus was found to be 60 to 90 nanometer. And as I already informed that there's a high sequence similarity of the genetic material of this this coronavirus, novel coronavirus, to the SARS-CoV. That's why the name has been given as SARS-CoV-2. So this structure, the outer structure of the coronavirus, it consists of the spike glycoproteins, as it is showing here, apart from which we are having the envelope and the membrane glycoproteins. So these are present at the outer membrane, which encodes the inner helical nucleocapsid comprising the viral RNA, right? So this is the virus, what we can see in the structure. Then how it invades to our lungs or pulmonary tissues. So this figure has been adapted from Kumar et al. 2020. So now we'll explain how this disease progress in healthy volunteers. So bringing the discussion of Dr. Barua yesterday, what he has informed us that an infected person, when they coughs or sneeze, the viruses are coming out to the environment in the form of droplets. So the droplets contains the virus particles. When a healthy person inhales those droplets, it reaches to the lungs of the healthy person. So the lungs, the cells, they are containing the ACE2 receptors. What is this ACE2 receptors? This is angiotensin converting enzyme 2 receptors. Why I am talking about this receptor? Because they are having the configuration to accept the spike proteins of the novel coronavirus. So when this virus reaches to that near to the cells, they are binding to the receptors, and following binding, there will be a conformational change of the receptor. which allows the internalization of the complex of this virus and the receptor. When it will be internalized, you can see here, when it is internalized, there will be uncoating. But uncoating will be favored by the low pH of the environment. And when there will be uncoating, the viral RNA genomic RNA will be released, which will use the endoplasmic reticulum of the cell to replicate and translate to produce the desired numbers of proteins and the viral RNA. What will happen? The cell is preparing all the proteins and the viral RNA. These proteins are again need to be assembled. Where it will be getting assembled? In the Golgi apparatus and the endoplasmic reticulum. So they will be assembled in the form of a new virus, a new coronavirus. So when it will be assembled, this will be coming out of the cells in the form of vesicles. So again, it will try invading to other healthy cells. So the process is ongoing if we are not treating this virus by using any proper treatment. And it will cause several complications of respiratory problems, respiratory distress. So what are the treatments available for this? According to Center of Disease Control and Prevention, there are no drugs or other therapeutics presently approved by the United States Food and Drug Administration to prevent or treat this COVID-19 disease. Then we know that there are several treatments are ongoing, right? So those are under the interim clinical guidance for management of patients with confirmed coronavirus disease. So these are just a guidance, no approved drug available for the treatment of this disease so far. So what has been mentioned in the guideline? So the first category is potential antiviral drug under evaluation for the treatment of COVID-19. If we see, under this, we are having two categories of drugs. One is remdesivir and the other one is chloroquine, hydroxychloroquine. But the question may arise to your mind that chloroquine and hydroxychloroquine, these we know that they are approved as malaria and widely used in the treatment of malaria as well. So here, the drugs are repurposed in the treatment of COVID-19. That's why they are categorized under antiviral drug here. The others are immune-based therapy under evaluation for the treatment of COVID-19. And the components included in it are convalescent plasma and immune globulins and interleukin 6 inhibitors. Apart from which, one more category is there, that is antithrombotic therapy in patients with COVID-19. So first, we will start with the potential antiviral drugs under evaluation for the treatment of COVID-19. So we have seen the first category, first drug was remdesivir. Remdesivir, actually, by seeing the vial, we can imagine that it could not be administered through oral route. So basically, this is given through parenteral route, particularly intravenous route. This remdesivir is a prodrug. So once we will administer this, there will be breakdown of this prodrug moiety, and it will give us the active form GS441524. The structure of this active form is similar to adenosine. So it's an adenosine analog, which interferes with the viral RNA synthesis. So this remdesivir is not yet approved for any kind of disease yet. So it is still under investigational stage. If we see the dose for this drug, this remdesivir, will find that the initial one-time dose of 200 milligram should be administered by IV infusion over a 30 to 120 minute time, followed by 100 milligram per day for 10 days. The side effects of this drug has been shown vomiting and nausea. Further, when it was tested in the clinical trials in patients with Ebola virus, it has been noticed that this remdesivir can increase the liver enzyme level in the patients, SGOT, SGPT. So the same thing has been noticed by the researchers when they tested this drug in COVID-19 patients in the USA. So we can imagine that we understood that when there will be conversion of this product to the active form, it will become the adenosine triphosphate analog, which will inhibit the RNA polymerases. So for this, we will just see a video on the mechanism of remdesivir, how it enters into the cell and how it affects the.
So I'm now going to discuss what we know so far from in vitro data about remdesivir's antiviral properties against coronaviruses like SARS-CoV-2. So before I begin, here is the cell membrane, and here's inside the cell, here's the nucleus of the cell with DNA inside the nucleus. So the mechanism of action has been described in this article here entitled Coronavirus Susceptibility to the Antiviral Remdesivir GS5734 is mediated by the viral polymerase in the proofreading exonuclease. This was actually published in 2018. So GS5734 is just another name for remdesivir. When a host cell comes into contact with the coronavirus known as SARS-CoV-2, SARS-CoV-2 infects the cell by a certain mechanism. So the SARS-CoV-2 coronavirus has proteins on its surface. These are what we call spike or S proteins. These S proteins allow the binding to the ACE2 receptor on the cell surface of a host cell. So once the S protein on SARS-CoV-2 binds to an ACE2 receptor on the host membrane, the host cell membrane actually invaginates. And that invagination process actually closes over, and it actually brings in the coronavirus in what we call an endosome. And then that endosome is brought into the cell and oftentimes fuses with a lysosome. This is the process known as endocytosis. So what happens is that coronavirus exits out of the endosome or the lysosome and unravels its viral RNA. So the viral RNA is the genetic code of the coronavirus or the SARS-CoV-2 virus. SARS-CoV-2 virus is a positive sense single-stranded RNA virus. So it's one strand of genetic code. This is what makes up the virus. Once the viral RNA is inside the cell, it hijacks the host cell's machinery, like ribosomes. Ribosomes are protein makers. You can think of them like that. And they look at this piece of viral RNA and they make a protein. They translate it into viral proteins. One of those proteins is what we call RNA-dependent RNA polymerase, or RDRP. RNA-dependent RNA polymerase, as its name suggests, it is dependent on RNA, so it needs RNA to function. And an RNA polymerase means that it makes RNA. So what it actually does is that it actually makes more viral RNA. So it looks and reads this piece of viral RNA to make more viral RNA. That is its function. These SARS-CoV-2 viral RNA are also used to produce other viral proteins like spike or S proteins that coat the viral envelope. And eventually, all of these viral proteins and the pieces all come together to produce new virus, new SARS-CoV-2 virus, that then can exit the cell to infect other cells as well. Now that we know how the SARS-CoV-2 virus can bind and enter and infect cells, how does remdesivir work? So when we give remdesivir via IV, Remdesivir can then enter into the cell and then be metabolized to its active form, GS441524. Remember that GS441524 is an adenosine analog, which means that it looks and acts like adenosine, but it really isn't true adenosine. Now, I didn't mention this before, but viral RNA, like our own RNA and our DNA, are made up of nucleotide bases. There are 4 nucleotide bases that are used, and they are slightly different in RNA compared to DNA, but in RNA, they are A, G, C, and U. So adenine, guanine, cytosine, and uracil. Those are the 4 nucleotide bases. GS441524 is an adenosine analog. Adenosine is a nucleoside. So what's important here is that GS441524 acts like, but is not the same as the A piece on RNA. So the RNA-dependent RNA polymerase, or RDRP, gets a bit confused. It thinks that this GS441524 is the A piece that is supposed to be used for making viral RNA. So it makes a mistake. It picks this piece up and incorporates it into the viral RNA strand. What happens is, so you can think of this piece here as the GS441524. As it's producing the viral RNA, it adds onto the viral RNA this wonky piece. And this piece is not supposed to be there. So what happens is this becomes defective. This viral RNA becomes defective. In fact, it usually causes the RDRP to stop producing the viral RNA after a couple more additions to the RNA. So we get defective and essentially inactive viral RNA. It's not able to do what it's supposed to do. That's how remdesivir and GS441524 enact its antiviral effects by inhibiting viral RNA production.
So this video shows how this remdesivir acts in the prevention of viral replication. So this video has been adapted from YouTube. Next, we will move to a recent study published in New England Journal of Medicine. In this study, they have included 71 patients, out of which 8 were discarded for the incomplete information. So out of the 63 patients they have included in this study, 34 patients were receiving oxygen by intubation or mechanical ventilator. So during the median follow-up after the treatment of the patients with remdesivir, it found on 18th day, it had shown that there is an improvement in oxygen support class with removal of oxygen intubation. There's a clinical improvement was observed in 36 out of 53 patients at the time of reporting. So this remdesivir has shown good activity against the treatment of this COVID-19. Next category we have, we were talking about are anti-malarial drugs, the chloroquine and hydroxychloroquine. If we see the dose of these 2 drugs are almost similar, 300 milligram per week. Why I am stressing here per week? Because when we will see the dose for these drugs in COVID-19, this will be differing. So present use of, earlier these drugs were used in the treatment of malaria, but we are repurposing this in the treatment of COVID-19. Then the dose, as I told you, it will be changed. So what is the present dose? If we see the chloroquine and hydroxychloroquine needed a dose of 10 milligram base per kg for a person or for a patient with 60 kilogram of weight need almost a double dose of its dose used in the treatment of malaria. But in malaria, we were using a single dose weekly. But here we had to give the loading dose first, followed by the maintenance dose daily, 155 milligram. So if we see the background of this chloroquine, we will find that these two drugs has been approved long back in the treatment of malaria. Chloroquine was approved in 1949, whereas hydroxychloroquine was approved in 1955. So when we are repurposing this in the treatment of COVID-19, we are increasing the dose tremendously. So when we are increasing this dose, we can expect these drugs will create more side effects to the users. Yes, they are producing severe toxicities to the patients. So this can cause abnormal heart rhythms such as QT prolongation. It can cause dangerously rapid heart rate called ventricular tachycardia. It can also damage to the eyes through macular degeneration or retinopathy. It can cause hearing problem to the users. It can cause bone marrow problem followed by blood disorders known as porphyria. It can cause muscle weakness, can cause psoriasis. So these are the different complications, apart from which there are several listed by the researchers. So these are the common side effects which has been noticed. So now, in order to evaluate these two drugs in the prophylaxis purpose, the recent clinical trial has been started. This clinical trial has been started this month in May, in this month, May month. So it has started recruiting, you can see here. So it started recruiting the healthcare volunteers. Basically, as I told you, that it will be using for the prophylaxis purpose. So this has been planned for the healthcare providers. So they are planning to include 40,000 healthcare providers from 50 to 100 sites. And the dose for this drug will be given as mentioned in our previous slide. So the 10 milligram per kg body weight as a loading dose, followed by 155 milligram daily for a duration of 90 days. So this is the purpose of the study, to evaluate its prophylaxis action to the healthcare providers. But okay, so next we will see this, how these drugs act on the viral cells. So if we see, you will find that this chloroquine, first mechanism includes the inhibition of virus binding to the cell surface receptor, the ACE2 receptors. After which we know that there will be unraveling of the viral RNA, right? So this drugs also prevents the release or unraveling of this viral RNA to the healthy cells. So they increases the pH of the cells, thereby it prevents the release of the viral RNA. Further, it also inhibits the phosphorylation of MAP kinase, which in turn inhibits the pro-inflammatory cytokines production and viral replication. Further, we come to know that after synthesizing, the viral particles are assembled in the Golgi apparatus. So this is also prevented by the use of chloroquine or hydroxychloroquine. Thereby, so the accumulation of viral vesicles within the trans-Golgi network has been noticed. So this is the mechanism of this drug, how it is working. But recently, last week, I can say, so shocking article has been published in the Lancet, where they have come up with the information that if we are treating this hydroxychloroquine or chloroquine to the COVID-19 patients, it can reduce, decrease the hospital survival. Means it increases the mortality of the patients within the hospital setup. We can understand this is completely different scenario. So we are using this drug in the prevention of COVID-19. Simultaneously, they are helping in the killing of the patients because of their side effects. So so it has also revealed an increased frequency of ventricular arrhythmias when used for the treatment of COVID-19, because of which this Monday, World Health Organization has recommended to stop all the clinical trials with chloroquine and hydroxychloroquine. This is the news, has been published yesterday, 26 May 2020, that the hydroxychloroquine temporarily suspended for any kind of trials. So this is a questionnaire session. So the news has been published in this Monday. So these were all about antiviral drugs. Now we'll move to the immune-based therapies under evaluation for the treatment of COVID-19. Immune-based therapies. So it includes the convalescent plasma and immunoglobulins. What is this convalescent plasma? This is the plasma. We are getting it from the recovered patients from COVID-19. The concept of convalescent plasma is not new. It has been, this concept was brought to us by Sir Emil Behring almost a century ago, for which he has received his Nobel Prize in Physiology and Medicine for the work demonstrating that the plasma could be used in the treatment of diphtheria. So the same concept we are utilizing here. So we are using the plasma from the people who have recovered from COVID-19. Right, so this convalescent plasma has been trialed as a therapy in previous coronavirus outbreaks during the SARS-CoV in 2003. So these studies had reported improvement in patients' diseased condition after receiving convalescent plasma without producing any evidence of serious complications. But whatever the reports has been published or available to us are small studies. Not a single large case reports are available in the literature. This convalescent plasma has also been introduced in the treatment of Ebola virus in 2013 to 2016. Several case reports showed promising results, but again, large-scale randomized trials were not performed with this convalescent plasma. So, but it has been shown that it can improve the patient's outcome. But the question may arise, from whom this plasma will be collected? Definitely those who are recovered from COVID-19. But how we will identify? So in order to identify the person, we must have the diagnostic test or a positive diagnostic test by nasopharyngeal swab at the time of illness of the patient. So we must confirm that patient has suffered from COVID-19. Or if the test was not performed, all the symptoms of the patient were positive and the tests were not performed, that's why we have to confirm it now by positive serological test for SARS-CoV-2 antibodies in the plasma of the person, those who are willing to donate. So these two criteria, when it meets, they can donate this convalescent plasma. Now the question arises, when they can donate it. So for this, we know it has been mentioned by in the guideline that after 14 days of complete recovery, they can only donate it. And this donated plasma can be used in clinical trials, expanded access, and single patient emergency IND cases. So in order to treat the COVID-19 cases. Recent news in Nature Biotechnology has revealed that in May 2020, it has revealed that convalescent serum lines up as first choice treatment for coronavirus. In that news, the chair of molecular microbiology and immunology at Johns Hopkins University, Sir Arturo Casadevall, he mentioned that the option rapidly becomes the best option without really demonstrating that it would work. Why? Because the likelihood of harm is very low relative to the possibility of benefit. So we can understand the usefulness of this convalescent plasma in the treatment of COVID-19, but still we are waiting for large-scale clinical trials and the recommendation by the CDC. Next, we will see the interleukin 6 inhibitors, tocilizumab. Basically, this tocilizumab is an approved drug against rheumatoid arthritis. It has been approved in 8th January 2020 for the treatment of rheumatoid arthritis. We are repurposing it here. Why? Because interleukin 6, the production of interleukin 6 increased in patients of COVID-19 when there is a binding of coronavirus to the healthy cells. There is increased production of inflammatory cytokines, including interleukin 6. When there is an increased production of interleukin 6 by the our immune cells, so it can lead to the inflammatory storm. How it is leading to inflammatory storm? By binding to the receptors, IL-6 receptors, which are present as soluble form within the body or in the membrane bound. So when it will bind to the specific receptors, it will cause dimerization of the glycoprotein 130. So when there is a dimerization of the GP130, it induces signal transduction by the classical method by using the JAK and STAT pathways, the genus activated kinase and signal transducers and activators of transcription pathways, which leads to inflammatory storm. And what will happen if there is an inflammatory storm? Actually, whenever we are having a small infection, there will be an increase in IL-6 production or inflammatory cytokine production, which causes an inflammation to the site of infection. That is for recovery of the site of infection. But when we are having this COVID-19 infection, the production of IL-6 is increased tremendously. There is an increased production of this IL-6, which leads to dysfunction of air exchange, acute respiratory distress syndrome, secondary infection, and multi-organ failure. It has been examined in the autopsy, during the autopsy of the COVID-19 dead patients, that there's an accumulation of yellow-colored fluid in the alveoli of the dead persons. This confirms the role of IL-6 in the COVID-19 patients. Then how it could be treated? If we administer this tocilizumab, it binds to the interleukin 6 receptors preferably, and it prevents the formation of dimerization. If there is no dimerization of the GP130, there will be no signal transduction and there will be no inflammatory storm. Thereby, it can relieve the patients from the respiratory distress and can improve the lifestyle of the COVID-19 patients. So apart from tocilizumab, we are also having sarilumab. So this is also approved in 2017 in the treatment of rheumatoid arthritis. And we are repurposing this, we are reusing this in the treatment of interleukin. But I just wanted to say it again, these are under evaluation, not yet approved for the treatment of coronavirus disease. To support the role of interleukin 6, systematic review has been published by Coombs and Hagbayan, where they have showed that there is an increase in production of this interleukin 6 in the patients infected with COVID-19. So it has been measured in plasma, and it has been found that there is a 2.6-fold rise in the production of interleukin 6 or level of interleukin 6. So while inhibition of IL-6 with tocilizumab, it appears to be efficacious and safe in preliminary investigation, which shown to decrease oxygen requirement, resolution of radiographic abnormalities, and clinical improvement. However, these results of several ongoing clinical trials should be awaited to better define the role of tocilizumab or other agents under this group in the treatment of COVID-19 prior to routine clinical application. So next, we will come up to antithrombotic therapy. Actually, it has been established there will be the formation of fibrin in COVID-19 patients, which might be due to the moderation in prothrombin factors in circulatory blood. The the predominant coagulation abnormalities in patients with COVID-19 suggest a hypercoagulable state and are consistent with uncontrolled clinical observations of an increased risk of venous thromboembolism. This is termed as thromboinflammation or COVID-19 associated coagulopathy by some experts. Thus, increase in fibrin degradation product, fibrinogen, and D-dimers in the circulatory blood have been reflected by increased incidence of thromboembolic disease associated with COVID-19 in patients in the intensive care unit. So it has been assumed, and several trials are ongoing, that with antithrombotic agents in order to establish the efficacy and to decrease the death toll and with COVID-19. So a brief report on has been published in the Journal of Thrombosis and Hemostasis, where by Panigada et al., where they have reported that acute intravascular coagulation within 24 COVID-19 patients admitted at the intensive care unit. So these findings may explain the events of venous thromboembolism could be observed in some of these patients, and support with antithrombotic treatment would be necessary in order to prevent the life of the COVID-19 patients. So these were, now we'll move to oxygenation and ventilation. When we have seen there is a cytokine storm, we have noticed there is decreased oxygen transfer, and there is condition of ARDS, acute respiratory distress syndrome. So in order to relieve to those conditions, there are 3 recommendations has been provided by CDC. So the first recommendation is for the adults with COVID-19 who are receiving supplemental oxygen. The panel recommends close monitoring for worsening respiratory status, that intubation be performed by an experienced practitioner in a controlled setting. Second recommendation is for the adults with COVID-19 and acute hypoxemic respiratory failure despite conventional oxygen therapy. The oxygen is provided through the cylinder by the usual method, but it is still causing the hypoxic respiratory failure. So in that cases, the panels recommends high flow nasal cannula for the acute hypoxemic respiratory failure. The last recommendation for this condition includes in the absence of an indication for endotracheal intubation, the panel recommends a closely monitored trial of non-invasive positive pressure ventilation for COVID-19 adults with acute hypoxemic respiratory failure. So this is particularly for whom there is hypoxemic respiratory failure, the high flow nasal cannula is not available. So in case the second recommendation, if we see, this is the second recommendation where it has been said that high flow nasal cannula should be provided. But if it is not available, then we can go for the non-invasive positive pressure ventilation. So this is the third recommendation. So these are all about the treatments, but the treatments are not stopped here. Apart from which, there are several treatments are ongoing in different clinical trials, in different stages of clinical trials, which includes the omifenofir, interferons, lopinavir, ritonavir, ribavirin, fapinavir, oseltamivir. So these are the different antiviral drugs which are at different stages of clinical trials. So those are the recommendation provided by the CDC. Now we'll move to future trend. We all are looking for an effective vaccine against this disease, COVID-19. This will be covered by Dr. Roy tomorrow. So we are waiting for the detailed information on vaccine. So we'll move to the next recommendation or future trend. So it includes the mesenchymal stem cell therapy. So mesenchymal stem cells are body's natural building blocks. So they have the ability to become more specialized cells with specific functions based on the microenvironment where they will grow, such as brain cells or blood cells. Because of its unique regeneration ability, the stem cells could be used for a wide variety of diseases around the world in near future. So this immunomodulatory and regeneration properties of the mesenchymal stem cells are more evident in the treatment of COVID-19. If we inject this mesenchymal stem cells to the COVID-19 patients, it has shown that the significant accumulation of these cells to the pulmonary environment has been noticed, which helps in the immunomodulatory effect, prevents pulmonary fibrosis, protects alveolar epithelial cells, and cure the lung dysfunction. So we hope that there will be some breakthrough in the treatment of mesenchymal stem cells in near future to prevent the COVID-19 in a better way, to save the life of the infected person. Further, this mesenchymal stem cells has shown to improve the survival rate of H7N9 induced acute respiratory distress syndrome. It has been documented, but still this treatment is under investigation. Next is we are also focusing on combination therapies. As we all know that if we use the numbers of drugs to target a single disease, we require decreased dose. If we are using the decreased dose, it can reduce the side effects. Simultaneously, if we are targeting different pathways in order to prevent the disease, the chance of getting a registration or resistant to the available treatments will be reduced. That's why the treatment of hydroxychloroquine has been combined with azithromycin. A report has been published in last month showing that if we combine azithromycin with hydroxychloroquine, then the growth of this virus can be prevented tremendously within a short span of time. But the study was performed in vitro on saline. So if we see how this azithromycin works, a different pathway has been established in the invasion of this coronavirus to the cells. What we have discussed earlier, that is through ACA2 pathway, but a different pathway, that is CD147 pathway. So this pathway is also used in order to invade the host cells by the COVID-19. So this azithromycin prevents the invasion of the viral particles through this pathway. So we are expecting some good combination may arise in near future in the prevention or in the treatment of this COVID-19 to get synergistic effect and reduce side effects of the drugs. Next is the herbal therapies. So this is traditional Chinese medicine. It has shown that use of Chinese medicine can clear the body's heat and remove the toxins in order to prevent the uninfected person from the infection of COVID-19. Further, if we treat the patients at early stage, that this traditional Chinese medicine can prevent the formation of cytokine storm. This can lead to improve the patient's condition. Apart from which, we are also using in India, IOS has recommended several herbal therapies, which is broadly covered yesterday by Dr. Indranil Chandra. So he has informed us to use the warm water, the recommendation by IOS to use warm water to perform yoga, spices, to use spices in our daily diet, such as garlic, ginger, and others, and to drink herbal tea or kadha, or to drink golden milk, several others. So these are already been published in the site of IOS, so we can refer to that. So that's all about this lecture. And to prepare this lecture, I had taken help from different literatures, as been mentioned here. And thank you all for your kind attention.